focus of this presentation this afternoon is on assuring access to services in rural places, advancing the health of populations in those places, and taking full advantage of provisions that are in the Patient Protection and Affordable Care Act, otherwise known as the ACA. Changes are occurring and will continue to occur, and as we approach 2014 and the kick-in of a lot of the subsidies and uses of health insurance exchanges, these will become very dramatic. But changes are underway in private insurance coverage through those exchanges when they're up in 2014. And with that will come pressure to contain costs. Changes are underway in many states now and in 2014 in the more dramatic way to expand the use of Medicaid as a coverage for many of the Americans who are currently uninsured. And with that will come pressure to contain costs. And with both of those, there will be acute pressure on the primary care components of our delivery system. As individuals and households move from a status of being uninsured and having any kind of access primarily through safety net providers, including emergency rooms of hospitals, to becoming insured and hopefully beginning to change their access pattern to use some kind of medical home and a primary care provider, that will increase the pressure on that part of our delivery system. And under all of that, and there's a reason for repeating those bullets, under the pressure to contain costs so that for society, healthcare remains affordable. But turning to primary care, why the emphasis on recruitment in primary care? First, an increased demand that will come through the federally qualified health centers, or FQHCs. Much of that has been underway. Increasing funding for FQHCs was a strategy in the Bush administration for expanding access for the uninsured. It remains a strategy to continue to invest more and more federal dollars into FQHCs. The most recent announcement of that was about a month and a half ago, another bolus of funding out to FQHCs. Well, with all that increased funding, those centers then are recruiting and retaining primary care providers. The growth in patient-centered medical homes that we expect to see as a result of both the reform legislation and another theme I want to emphasize today, it's not all because of the reform laws. Many of these changes are underway regardless of the ACA, and this is one of those. The patient-centered medical home is a model the Veterans Administration is turning to in a major way. It's a model a lot of private insurance carriers are saying this is how we want to help move the delivery system. That increases the demand for primary care providers. Primary care providers would be a foundation, is a better term than bedrock, of the new accountable care organizations. We don't know detail of what these organizations will look like. There is a federal rule due out sometime this month, more likely to come out shortly after the first of the year, beginning to define this. But even articles like I was reading this morning about specialists saying we want to be able to establish ACOs acknowledge the need for primary care even when the core support might be coming from specialists. Compound all of that with an increased demand on recruitment and retention, and what that means for trying to recruit and retain primary care health care professionals into rural areas. Always been a problem. Most of the nation's shortage areas for primary care are in rural areas. It will become an even more imposing challenge with all of these expansions of access. So how do we respond to that? One way is building the supply through the use of what are called pipeline programs, programs that begin to try to establish interest in the health sciences in the elementary grades and carry that all the way through training in the healthcare professionals. And I threw up a few states that I know have solid examples of this. One that I recently left, Nebraska, West Virginia, South Florida, and various area health education centers, or AHECs, also emphasize pipeline programs. The ACA provides assistance for this in new grant funding or expanded grant funding, specifically in Section 5102 of the law, state health care workforce development grants to promote career pathway activities. So that's one funding announcement to be on the alert for as the money starts rolling out to support workforce activity. And some of that did come out about 5 months ago. There'll be more in the future. Another way to focus on building supply, especially in underserved areas, is through the use of financial incentives. It might get us at least closer to a level playing field in income expectations that a new physician might have, or a new physician assistant, or a new nurse practitioner. There are provisions built into the ACA that assist with that in both Sections 3102 and 5501 that focus in 3102 in particular on improving payment through bonus strategies for practicing in underserved areas, and extend the floor payment for the geographic price. Boy, I'm forgetting now what the whole thing means of GPCI. Should always write out acronyms. But it's a geographic adjustment done in the payment system that had people paid below the equivalent of the mean in some areas. The legislation brings everybody up to at least that mean. And it has a huge difference for rural practices. We've got some policy briefs on our site if you're interested in the statistical detail. Loan repayments are also helpful to try to attract individuals into underserved areas, whether it's a state loan repayment or a federal loan repayment. Some of that's been affected by the ACA. Section 5201 increases the commitment to a 10-year commitment if you're receiving the loan repayment. 5202 for the first time creates a loan repayment program for nursing students. 5204 for the first time creates a loan repayment for the public health workforce. And 5205 for the first time loan repayment for allied health. So those are programs that can be helpful to AHECs and others that you work with to try to attract the healthcare professionals, and not just physicians now, but nurses, public health workers, allied health, into our underserved areas. The bonus payments to practice in shortage areas were reinforced and enhanced in the ACA, and increasing payment for safety net providers is another strategy. More strategies for how we can work to build the workforce is looking at the working environment. And there are two major pieces to looking at the working environment. One of those is, who do I interact with as a professional, and how am I supported within the community and with the community of healthcare professionals? And second, how do I maintain my skills and also deal with problems of being on call? So there's the who do I work with, and there's the issue of being on call. Now, how are those addressed by changes either in the law or actually reinforced by what's in the law? The creation of patient-centered medical homes is seen as dealing with the working environment because it brings together a number of professionals into single teams and uses payment incentives to enhance that mode of delivering health care. It's promoted in the ACA along with community-based health promotion, which changes the environment, and that's in 3502. And then mitigating on-call, dealing with that from requirements for staffing emergency rooms so that you can use a variety of professionals to staff emergency rooms. It does not have to be the physician on call 24/7. Some of that may begin to come to you at state level because it may require some changes in scope of practice so that somebody at a different level of professional training can be the first responder in critical access hospital emergency rooms, for example, in our more remote communities. Building the supply, the optimal use of all healthcare professionals will be important in doing this, that everyone practices to their maximum skill level. What that can mean is relief for some of the professionals like physicians who now perform tasks that could be performed by others. So if you create patient-centered medical home and teams, and within that team you include a physician or other primary care provider as sort of the leader of the team, within the team you can have other levels of professional training that can handle a lot of patient needs without you and I as patients needing to see the physician every time we go into that office. That frees up the physician to do what is at their skill level, and it may even mean more than a 5-minute office visit if ultimately we need help from the physician. Nurse-managed health clinics is another expansion of services that's built into the ACA in Section 5208. This is a way of trying to extend primary care through the use of as it says, nurse-managed clinics. Alternative health care providers can increase access in dental care in rural and underserved areas, and there are encouragements for that through grant programs in Section 5304 of the ACA. And community health workers can provide guidance and outreach, particularly in our frontier areas. When I was in Nebraska, that was about a third of our state. And they're created as a category of professional in Section 5313 without requiring, these are community health workers, so you're not requiring scopes of practice, et cetera, for that level of assistance. And then primary care extension agents who help with follow-up on treatment protocols, and that's in Section 5405. We've begun to see some of the funding for a lot of those provisions I just rattled through. Funds that were released in June for 500 new primary care residency slots, support for training 600 new physician assistants, 10 new nurse practitioners, and a $5 million for state workforce planning, all released from Health and Human Services in June of this year. Other funding that we're seeing coming through, $29 million for the National Health Service Corps, funding that was announced a couple of weeks ago, $8 million additional training grants to community health centers a little earlier in November, $355 million in October for community health center applications that are due in January 6th. So these are announcements of the release of the funds, some of which are allocated out, some of which are not yet because it's a competitive grant process to secure a share of those funds, and $320 million in September to 6 national programs related back to some of those concepts like patient-centered medical homes, accountable care organizations. Innovation in providing services will be critical with all of that increased demand for primary care services and trying to continue to make services available in rural areas. We have to look to innovation. And to do that, we would shift the focus from traditional provider-based thinking to patient-centered thinking. And what I mean by that is when we think about workforce and we think about health care in a community, generally, and as being a policy person for the last 20-some-odd years, I think in terms of, well, the hospital for the community or the clinic for the community or the physician for the community. We're really trying to turn that around and say, what do the patients need and how do we get that service to the patient, which may not mean a local hospital. It may not mean a full-time physician in that community. Focusing on the services that are needed. That may be through use, and a couple of the next slides will do this, it may be through a better use of telehealth and telecommunications as an example of extending services from where a provider is to where the patient is. It already underlies one of the payment adjustments for primary care services in the ACA. The use of telecommunications that can be done for trauma services, which helps with quality of life for the providers because it deals with that 24/7 being on call in the ER issue. If your ER can be covered with telemedicine in a teletrauma service, as Avera Health does in South Dakota, you don't have to have the physician in your local ER. What you need to have is, say, a nurse-level professional in communication with a board-certified emergency room physician in the mothership or central hospital of Avera Health. Pharmaceutical services, especially in hospitals, North Dakota is using this approach through the use of telecommunications and a dispensing machine in a hospital. You can have a trained pharmacist reviewing all of the orders, communicating with a pharm technician or a nurse in the local rural hospital, dispensing the medication in the correct dosage through a machine, and then taking that to the patient. And consulting support for primary care providers by connecting them through the use of telecommunications. Integrating care across the continuum is something that I emphasize a lot. Again, with a patient perspective, if I'm living in a remote rural place like Broken Bow, Nebraska, I don't want you to think only about the primary care I might need and thereby putting a satellite clinic in Broken Bow. I want you to think about the full array of services I need and make sure I connect to them in some way. The building block for that is primary care, and medical home would be a way to do that. It can be promoted by states in using the Medicaid program, and many states are now moving in this direction of the patient-centered medical home as a model for delivery of services. North Carolina is one of the pioneers in this activity. improvement of care management through patient-centered care, so we're managing the care across the continuum even if it's not all provided locally. And that can be embedded within the context of the new accountable care organizations as they roll out, and that's in Section 3022 of the law. The focus should be on community health and well-being. Ultimately, we're talking about patient-centered care, consistent with the goals of primary care, which is care across a continuum that is comprehensive and continuous. The old concept of community-oriented primary care is resurgent under some of the patient-centered medical home ideas, but now within this concept of patient-centered primary care. If we follow that logic and precepts, we can actually improve the delivery of services and improve the health care status of our population in rural places. Some of that can be enhanced even further with the public health programs that are built into the ACA, and that's in Title IV. The Prevention and Public Health Fund that is in the early sections of that title grows to $2 billion a year by fiscal year 2015 and annually thereafter. There's an education and outreach campaign regarding preventive benefits built into Section 4004, grants to school-based centers, and grants for community transformation. And I just heard earlier this week those are likely to be rolling out within the next few months. Also in Title IV, health aging grants for programs for individuals in my age cohort between 55 and 64. Demonstration project concerning individualized wellness plans within the Medicare program to bring that to perspective. And research optimizing the delivery of public health services. All of those are grant programs built in to Title IV. So those are ways in which we can improve access to services in rural communities. And again, for point of emphasis, the access to services isn't under some rubric or model where we think about how we can place services in communities. It's how we connect people in the communities to the services they need. Many of which will be local, but some of which will be locally provided by providers at some distance through the use of telecommunications. I've included information on two different sites here, one from an expert panel that does a lot of analysis of legislation like the Affordable Care Act, and one for our research center that puts out more research focused than expert judgment and analysis, and contact information for myself.